All right, welcome future doctors. Today we're diving into a definitive, high-yield explainer on odontogenic infections. As a maxillofacial professor, my entire goal today is to get you completely prepped and bulletproof for your board exams and those upcoming clinical rotations. We're going to be detailed, we're going to be thorough, and we're leaving absolutely nothing from our source material behind. So let's get right to work.
Here is our syllabus for today's masterclass. We'll be covering microbiology and stages, pathways of infection spread, facial anatomy and spaces, navigating deep neck spaces, principles of infection management, and finally, bone necrosis and complications.
Kicking things off with Section 1, Microbiology and Infection Stages. You absolutely have to memorize this bacterial breakdown. Odontogenic infections are largely caused by endogenous bacteria that are already hanging out in the oral cavity, and they are highly multi-microbial. You're dealing with gram-positive cocci like streptococci and staphylococci, gram-positive rods such as actinomyces and lactobacillus, and gram-negative rods like fusobacterium. When the local environment gets thrown out of balance, these virulent microbes multiply and invade.
Now, these things don't just spring up overnight, right? They follow a very predictable three-stage progression. First up is inoculation. This is where microbes enter and trigger your host immune defense, showing up as localized inflammation. Second is cellulitis. Now, this is an acute, diffuse, painful, and indurated swelling of the soft tissues that spreads right along the fascial planes. And finally, an abscess forms, which is a true disintegrated tissue cavity that's completely filled with a collection of pus.
Listen, this concept is a classic exam trick, so definitely take notes here. In neglected cases, an abscess can eventually rupture. If it forms a sinus tract, well, that's just a one-sided drainage pathway originating from a single compartment. However, a fistula is an abnormal, epithelialized communication that literally bridges two distinctly different compartments. You have got to know the difference between a single-compartment drainage and a two-compartment bridge.
Moving right along to Section 2, Pathways of Infection Spread. So how do these bugs actually travel? It's all about the path of least resistance. The usual culprit is deep caries leading directly to pulp necrosis. Without treatment, pressure builds up inside the tooth, strangulating the blood supply. The crucial sequence you need to know is bacterial invasion from that necrotic pulp pushing down through the cancellous bone, actively eroding the cortical plate, and finally breaching out into the soft tissue facial planes.
And remember, pus is opportunistic. It's going to travel based on the tooth's exact position in the dental arch, the thickness of the surrounding bone, and the local muscle attachments. But here is a massive clinical pearl for you. It takes about 10 days before you can even detect these bone rarefaction changes on a radiograph. Seriously, do not rely solely on X-rays for early, rapid-onset acute infections.
Okay, let's get into Section 3, Facial Anatomy and Spaces. This is a core anatomical concept that honestly trips up a lot of students. Fascial spaces aren't actually empty rooms just waiting to be filled. Not at all. They exist purely as potential spaces. They are tightly bound layers of fascia that only become true spaces when they are violently forced apart by pus, blood, surgical drains, or even a surgeon's finger during an exploration.
When we talk about the supramandibular muscles, you really have to nail down those origins and insertions. Take the masseter, for example, originating from the zygomatic arch and inserting right into the mandibular ramus. You need to know this anatomically because when an infection, usually from a mandibular third molar, hits the masseteric space, it causes severe trismus. That means the patient physically cannot open their mouth and they'll be in severe, throbbing pain.
For the boards, categorical chunking is your best friend. We divide these areas into primary and secondary spaces. Primary spaces, like the maxillary buccal or the mandibular submental and sublingual spaces, directly border the tooth-bearing bones. Secondary spaces, on the other hand, like the masseteric, pterygomandibular, or lateral pharyngeal, become involved only as the infection takes that path of least resistance deeper into the structures of the face.
Let's turn up the heat a bit. Section 4, Navigating Deep Neck Spaces. This is where the stakes get incredibly high.
Mentally visualizing this deep anatomy is absolutely critical. If an infection spreads into the retropharyngeal space, your patient is looking at severe neck stiffness, dysphagia, and dyspnea, because the infection is actually bulging the posterior pharyngeal wall forward. And right behind the retropharyngeal space lies something even more sinister.
The danger space,
Guys, this is pure exam gold. It's a potential space located between the alar and prevertebral fascia. So why is it so dangerous? Well, it acts like a direct, uninhibited highway from the base of the skull straight down to the diaphragm. An infection here carries a massive, life-threatening risk for mediastinitis. If you miss this clinically, you lose the patient. It's that simple.
Bringing it back to the clinic now, Section 5, Principles of Infection Management.
Out in the real world, your clinical workflow has to be systematic and frankly unforgiving. Step 1. Completely assess the severity of the infection through a detailed history, progression rate, and a full set of vital signs. Step 2. Evaluate the patient's host defense mechanisms. And Step 3. Decide immediately if this patient requires treatment by a general dentist or a rapid referral to an oral maxillofacial surgeon.
You need to lock down these exact compromised host defenses in your memory. A patient's underlying medical condition totally dictates their ability to fight the infection. Poorly controlled diabetes, malnutrition, end-stage renal disease, or patients on immunosuppressive therapies like corticosteroids or cancer chemotherapy will drastically compromise their host defenses. Knowing this changes your entire management plan from conservative to highly aggressive.
And you absolutely must initiate a rapid referral if you see any of these red flags. We're talking difficulty breathing or swallowing, a temperature elevated over 101 degrees Fahrenheit, or moderate to severe trismus where their interincisal opening is less than 20 millimeters. These are giant warning signs that the infection is winning and advanced surgical airway management may be imminent.
Wrapping things up with Section 6, Bone necrosis and complications.
You've got to know the defining diagnostic criteria here. It's a classic comparison. MRONJ, or medication-related osteonecrosis of the jaw, requires over 8 weeks of exposed bone in a patient taking anti-resorptive or anti-angiogenic drugs. On the other hand, osteoradionecrosis, or ORNJ, requires over 3 months of exposed bone. And why does RNJ happen? Because radiation causes the 3 H's. The tissue becomes hypovascular, hypocellular, and hypoxic. The bone simply becomes way too weak to heal itself.
Finally, we need to carefully distinguish between periorbital and true orbital cellulitis. True orbital cellulitis, which often spreads from an ethmoid sinus or a maxillary dental infection, is an infection of the tissue situated behind the orbital septum. This is a profound drop-everything medical emergency. It can rapidly cause vision loss and intracranial disaster. Management might even require a surgical canthophyxy just to save the optic nerve, and it absolutely requires IV antibiotics capable of crossing the blood-brain barrier.
So, I'm going to leave you with a final pop quiz to test your clinical readiness. Think about this. If a neglected mandibular infection works its way back, breaches the retropharyngeal wall, and actually enters the danger space, do you truly understand the speed and anatomical severity of what you just learned? Because the distance from the skull base to the diaphragm is just one continuous fascial plane away. Review your spaces, know your microbes, and always trust your clinical exams. See you all in the next master class.